Good evening, everyone. Thank you all for joining us here today. We are talking about workplace violence, but specifically wanting to have an opportunity to share stories, solutions, and support. Workplace violence is a real challenge for a lot of us. The nursing profession is one of the hardest hit in some ways, and that's sometimes a surprise for folks. It's less of a surprise for folks who've been working in the profession for a little while. And so it's a real experience that we all have to deal with. And so we wanted to create some space for us all to come together and share those stories, hear from each other, hear our experiences, and hopefully support one another and maybe find some solutions along the way as well. So just to introduce myself very briefly, and I'll ask a few of the others if you jump in to share a story, please jump in and introduce yourself when you do so. So we'll just have a brief introduction. But my name's Eric Small. I have been doing some of the content for Birchwood Solutions and for Care for Nurses here. I wrote a couple of articles just this month on workplace violence, and please take a look at those if you get the opportunity. There's some good data in there that gets into some of the nitty gritty. Um, but we want to do a couple of things with tonight's discussion. We want to make sure that we are being respectful of each other's experience. It is a hard topic. It is a topic that can bring up a lot of feelings and emotions for folks, and we want to leave space for that. And we want to really make sure that we're respectful in our communication with each other and avoiding that pitfall that I know so many nurse leaders and managers and especially administrators sometimes get into, which is that what could you have done better? What could you have done differently? Right? We want to allow that space for that nurse who's sharing a story to get into that. And we can certainly share optimizations where available, but avoiding that where we can. So sharing those stories and experiences, we can talk a little bit about contributing factors, what we might get into there, talk about solutions and prevention strategies, and talk about how we support each other, how we recover from these events, and then what are some of the next steps we can take. So those are all the potential topics that we'll be getting into today. I really just want to start by opening up with a couple of statistics, and then we'll get into some more story sharing. 1 in 4 nurses have been assaulted in the workplace. That's a pretty staggering statistic when you think about it. If you're working on a shift on a typical size unit, you've got at least 3 or 4 other nurses there with you, often more. Somebody on that unit who's working that shift with you has experienced workplace violence. There's a 6 times greater risk of workplace violence than in most other industries in healthcare. And between 30 and 60% of incidents are unreported. And so likely those statistics are underrepresentative of the actual experience of our nurses. And I just want to put that information out there so that folks understand the scope of what we're talking about tonight. All right. So I want to just begin really, really simply by opening it up to ask, what types of workplace violence have you encountered or witnessed or heard shared from others in your experience or in your career? Anyone on the call who wants to share a story, I would love to hear from you.
I feel like I'm pretty lucky because I haven't had like major issues. I've definitely never experienced any physical violence. So I feel really grateful actually after hearing those statistics. Um, I think some of that's because of the field I was in. It was not one that I felt like there would be a lot of that. But definitely some verbal abuse um, from patients, doctors, and co-workers. So, just um, but yeah, so I guess I'm gonna say I'm pretty lucky or fortunate for that. So
AB, you highlight an interesting point and something that I could include up top as well, which is that when we talk about workplace violence, there are different stages or different tiers of workplace violence, and verbal abuse is considered, at least with the ANA, they consider verbal abuse part of that workplace violence. Some of those other statistics, when we're comparing against other industries, It's usually talking about the physical assaults and battery that happens, but in terms of the ANA and in terms of within that medical profession, verbal abuse is absolutely workplace violence. And lateral violence or lateral incivility is the most euphemistic term I've heard for it.
Yeah, it's a
Bullying
nice
is
way to
what it
say
really is, right?
it.
Is also workplace violence. So it isn't just those physical violence, but I'm grateful to hear that you did not experience physical violence in your career. Um, I have not to dominate too much time, but I've on a number of occasions experienced some level of workplace violence, and I'll share just a couple of very brief examples just to might engender some memory. So I've also had the times where I've been sort of verbally accosted by an upset patient or a patient with some mental health disturbances or substance use disorders, and those are co-occurring things with workplace violence in a lot of cases. And so it's okay to recognize those facts and have empathy for that, but also not tolerate the behavior. Um, and that was a fine line that we had to walk in a lot of cases. Um, I worked in an inpatient med surg unit on a major university medical center, and so we got all kinds of patients, and some of the most violent patients were not necessarily likely to cause injury, but oh man, they left you exhausted and in pain at the end of the day, and that was our little old folks with dementia. Um, uh, or other memory illnesses that we encountered. The bites, scratches, couple of those folks had more strength than you'd expect, given their chronological age and some of their ailments. But I've experienced a number of those kind of instances, and so that might be something that would trigger a memory for somebody on the call. I've also had a patient who did not fall into those categories, who assaulted me. Battery, I think the technical term. Assault covers a broader scope. Battery is when you're actually struck. That's a legal term, though. The Had a patient who was just very upset, very frustrated. Some of that was warranted, right? They were in a tough situation. We'd had a number of escalating behaviors with family members, trying to help manage this patient's safety related behaviors in the room. And is that we were getting ready to discharge the patient. She almost made it out the door, and she was a smaller woman, and it was not not a strike that caused injury, but she was of sound mind. And when I told her that she needed to return to her bed and not be out in the hallway, she just right in the chest. And I got to see some interesting systems from that. Our facility had been going through a lot of growth, and so I can get into that story here in a little bit as we talk about some of the responses to those things. But just to share, I certainly have encountered my fair share of workplace violence from patients. Any other examples, or did that bring up anything? Was that Deanna? Are you chiming in, please?
Yeah, and I do think it's interesting that we are I as a person am much more cautious and aware when it's people that I expect to be a little more violent, right? So I expect that people with mental health or that are withdrawing from substances to be a little more violent, a little more verbally abusive. So I'm much more cautious around those folks. I'm not as cautious around people who are not. And it's interesting as we're talking to be aware of that fact when I do realize that anybody can be violent at any point, especially when the expectation is that we're supposed to be able to take care of every single need that they have. And we can't, the frustration is always going to be there because of the expectation of that they and their family have coming in. And so I do recognize that, you know, part of this whole process too is that we don't put family in there. And I've seen family violence occur as well, and family to patient violence,
Hmm.
right, as part of all of this. And then how do we as staff, what do we do and step in between all of that, trying to control that on some level. So it's in a whole interesting kind of conversation as we roll through this about how just a simple escalation and how quickly that occurs and can catch you off guard just like that. It's just amazing.
Yeah.
It's just amazing.
And you just touched on something that I think is an important call in, which is sometimes we can experience some of the vicarious trauma, right?
Mhm.
You talk about patient violence or family member violence toward patients or vice versa.
Right,
And we can experience that and feel the stresses and feel the trauma of those occurrences as well.
Yeah, I was thinking that I hadn't even thought about that as being part of workplace violence because yeah,
right,
that yeah, I would say 100% of nurses have seen that.
right,
I mean, it's not funny, but like I hadn't even thought of that as workplace violence, but yeah,
right.
I mean it is.
And because I feel like I take that home more than I do, if somebody happens, I shouldn't say if they happen to hit me, they hit me intentionally when they hit me, but, you know, and I don't dismiss, right? I don't dismiss that they hit me and I don't dismiss that I got scratched or bitten. I don't dismiss them, of course, but when it comes from family, that's a different space for me. And I tend to
Hmm.
take that or carry that a lot longer than I
Yeah.
do patients, right? When staff, bites at me or does something, I carry that longer too. So that's kind of a different way too of talking about that or looking at that.
Yeah, and I mean, I can speak to in my experiences that I've had the escalating behaviors. I've
Hmm.
not experienced violence personally from a visitor, but the escalating behaviors that I've seen in visitors have always been a little bit scarier
Hmm.
than and carrying that I think is a good way to phrase some of the feelings that I have related to that. Those are the times when I've still had that little bit of fear. We have
Hmm.
an element of
Yes,
control might be too strong a word, but we have an element of control. There's a dependency, right, with our patients given their
right,
circumstances, and so that both creates uh, uh, that burden that we carry. Hey, we're here, we're responsible for them in some way. Um, and so while we don't dismiss the behaviors, as you said, I think that's a really good thing to point out. We have a better understanding of
right.
what has led to those behaviors, where that's coming from, and what's going on, and we can sometimes um, have that empathy. But then when it comes from those other places, it's more like, well, what did I do, right?
Right.
We're not going to
Right.
get into that too much, but
Or
like at the
no,
same
it's
time,
I think it's more,
you
I'm
carry that,
sorry,
you feel
Eric.
that.
I
Yeah.
I think it's more it triggers something in me,
Oh,
right?
okay.
Right. It triggers something.
Mm-hmm.
It's not so much what did I do as so much as it triggers something that I'm like, should I walk to my car by myself?
Mm-hmm.
Right? Because this family is still here. Am I safe to go outside? Like it just triggers something that's so different than what a patient triggers when a patient is violent towards me.
Yeah.
And I just that piece of that just feels so different than patient violence.
Mm-hmm.
A staff being violent towards me, do I have to worry when I leave that that's going to come with me? Right.
Yeah. Yeah.
I think that's more kind of where I was going. Like, is that when I say I carry that, that's kind of that difference,
Sure,
Well,
right?
sure.
that's the whole patient thing. It's kind of like when someone acts badly towards you and you find out that they're sick,
Hmm.
you have different compassion than when they're just being a jerk. I mean, maybe
Right,
it's like that.
right.
But yeah, and that's a little bit more, I think, Mike, what I was kind of leaning into. But I think I hear now what you're saying, Dan, about just that there's a more direct situational tie, right?
Right,
You can remove yourself from the patient encounter, and you know that you're removed from that patient encounter.
right.
With those others, it's harder to know that you're in a safe place. Is that
Yes.
closer to what you were
Yeah.
saying? Yeah.
Yeah, because you've built up some equity, even if the patient doesn't like you or it has been a difficult, you have some equity in that relationship. You feel like you almost have, this isn't really going to come out the way I mean it, but like you have authority
Right.
in that situation, whether they accept that you have authority or not. But there's a, like you said, the known, but you have that relationship, whether it's good or bad, you have some authority in that situation. It's the known.
Hmm.
And then when something comes in from the outside, and yeah, it's like, are they going to be waiting? Are they going to follow you out to your car? I
Hmm.
mean, that's a real thing, Are they, did they bring something in?
Right.
That do they have something in their pocket that made it through the detector, kind of thing? Or if maybe there's not a detector at your
When you have a detector,
facility.
yeah.
Um, so yeah, I mean, yeah, that's a whole thing I hadn't even thought about.
Sorry.
So no, it's like, but yeah, I mean, yeah, I think that's definitely scarier. Um, and it
I've
also too, like I would always go home with when you say it stayed with you longer, um, I always it made me sadder
Yes.
afterwards to even if it wasn't directed at me as the nurse, but like if there was that argument or whatever between the family member and the patient, the spouse,
Hmm.
whatever, it just made you it it made you realize how much one of the hardest things of being a nurse sometimes is like you can fix what they're there for, but then when you see all the other, you've got to send them back home, and
Yeah.
you've cleaned that wound and given them antibiotics. They're about to go back into this like horrible, dirty, nasty apartment with no Neosporin, kind of, it's like
Right.
you, and then when you see something like that, like violence, and you're like, oh man, I'm gonna, it just, the sadness, I guess, or that heaviness is what would stay with me, I guess, more
Hmm.
so than the fear so much of like, just there's nothing you can do about it. I mean,
Right.
you would see that's, wow, that's what that person's going to go back home to. And that's hard.
yeah, yeah, yeah. I've seen a lot of growth. You mentioned, the something that gets past the metal detectors. We at our facility and in our the facility I worked at the time was overall uh, took safety very seriously, but it was one of those things that had to just be a constant,
Hmm.
constant push from the staff to advocate for, can we get building lockdown, like limited access to the building? Can we get locking doors onto the units? Can we get, and it was because of situations, usually it was the upset family member who made a threat. Sometimes the threat was, you know, uh, had some legitimacy or felt like it might have some validity to it, and other times it was just somebody blowing off steam. But you try to take it seriously, even when you thought it was the latter, of course. And for a long time, I know at least, just as we were talking, I could think of several times where I had nurses who chose to say, hey, call down to our security department. And thank goodness we had a pretty well staffed security department, and said, hey, can somebody walk me to my car? I just don't know. And we had the support, and they would do that, which was good. But it was um, real times where that safety uh, wasn't as guaranteed
Right.
outside of there. And I had seen, so I practiced in direct care areas up until 2022. That's when I transitioned into more administrative roles and moved away from direct care um, areas, even though I was a nurse manager there, but I was in that space. Um, and again, I saw a lot of growth in the facility's ability to respond to things. What were the safety features we had in place? What were the safety features we were putting in place? What were the plans we had for the future? And it was an active part of some of those discussions. Um, but I also saw, and some of this I think often gets blamed on COVID. I don't know if that was always the inciting factor, but I also saw escalating patient and family behaviors in my time as a nurse from, the 10 years preceding COVID as when I was a nurse. And you know, there's a lot of causes and a lot of things that I could, point to and diagnose, but it was mostly just folks bringing in the stresses of their lives, compounded by whatever stresses were going on because they were here in the hospital, right? Their baseline levels of stress were higher.
Absolutely.
And so it made it so much quicker that switch would get flipped or that escalation would begin. And I tried to, again, carry empathy for that where I could and explain the limitations of what I or my staff could provide in the situation to try and de-escalate. Like, hey, this is our role, this is our capacity. We can't fix the fact that your insurance denied your, sniff stay. So now your family member is going to be here, which is 4 hours away from home for another week, right? That's beyond our ability. We've done everything we can. That's the thing that's the patient's angry at, but you're the messenger. Man, that's a tough spot to be in.
I feel like that's part of our job description,
Mhm.
being the messenger.
Yeah.
That is so hard. But again, I think it goes back to that expectation, that we all as humans have, right? Is that, well, you're the nurse, you're supposed to be able to fix it.
Yeah.
You're the doctor, you're supposed to be able to fix it. And it doesn't matter what it is. I have a pharmacist friend that yesterday was telling me that their computers went down and every single person that came into the pharmacy asked him exactly when the computers would be back up so that they could get their prescription, right? And that's I mean that it's a silly example, but that's the best example. When he said that, I was like, that is the absolute best example that I could bring to this particular conversation tonight because we all have expectations, right? And because he's a pharmacist, he should be able to fix that computer.
Right.
And again, nurses and doctors should be able to fix everything that there is to fix about hospitals, and medical care when it's so far out of the boundaries of what can be done. But
Yeah.
I think that human expectations get so far in the way of reality, you know, and part of that is that whole insurance
Yeah.
space that's so far removed from what we can actually do and take care of.
I just had a sad thought that, are people just being more entitled and they now have the gall to yell at the pharmacists, whereas in the past they might not have. Like, I don't know where to go with that statement. I just throw
Yeah.
that in there to stir up the
That,
pot.
Yeah,
I think,
I think that's a true statement
yeah,
just in general, an unfortunately true statement in
yeah.
general of our population. Um,
Yeah.
but yeah, I was actually thinking, Deanna, when you were saying that, I was like, you couldn't pay me enough money to be a pharmacist at Kroger or Walgreens because I have been in line getting my stuff, and I mean, I have heard people say the just
Yeah.
horrible things to
Yeah.
them. And
yes,
but yeah, I think it is, they're just I think yes, the expectation is there because well, you're in that position, you should be able to do something. Why can't you do something? But then I also think the other side of it is, yeah, as a population, I think we've gotten we've lost our manners.
Well,
We've
Um,
everything
created monsters.
I
we
mean,
we
and I
have so
think
many
it's,
comforts, we
Yeah.
yeah,
expect things now.
Yeah,
yeah.
I mean, I would agree. I would agree, certainly. I hesitate to use the word entitlement. I that carries something for me, and so
Mhm.
I tend to try and stay away from it. But I
Is it because
think
you're younger than we are?
maybe I think that it gets directed at me sometimes. Um, but genuinely, in my experience, rarely did in my experience with patients, when a patient was upset or when a family member was upset, it was rarely a sense of I did see folks who felt very entitled.
Sure.
Um, Oftentimes it was the folks who were not of my generation and younger.
Yes.
um, Often it was folks, and I mean absolutely no disrespect to these folks' experience, but it was people who were used to caregivers who could spend more time with them.
Yes.
Their prior experiences were caregivers that could spend more time with their given patient. That was the model that they grew up, or in the healthcare system, that was their experience with the healthcare system, and then not having that disconnect created a lot of entitlement. Um, I do see, and this is a little broader in terms of generationally, and certainly would apply to my own and younger when we dealt with folks in that space. Um, there is that sense of the instant gratification, and I separate that a little bit from entitlement. But attention spans are shorter. There is because so many other services are rapid and on demand and ready to go. Why is this not more like that? So yes,
Agreed.
I did see some of that, but I
Yeah, you
I
said it.
bristle
You
I
said
bristle at
it.
the word, and I draw that I draw that
Right.
distinction.
Agreed. Yeah.
I think
You said it
instant
better than I was trying
gratification
to
and
say.
entitlement are two different things.
Yeah,
And I
yeah,
mean, I think there are people that fall in both camps
yes, for sure.
or either or camp.
And yeah, don't get me wrong. I will. I have definitely seen folks
Well, and I
who
think
would fall into that entitled category.
some of that entitlement is, depending on where you're practicing.
Right.
I mean, I think, and also your demographic
Sure.
of who you're, what kind of field are you in, what kind of clinic are you in, what kind of a facility do you work in? Those things play into, is it entitlement or is it
Yeah,
other stressors, kind of thing. So yeah, I mean, we could talk for hours over all
yeah.
of the
But
psyche
I
of
think, right, we
that,
could
but
pull us back to the COVID conversation,
Mhm.
right? And the idea of workplace violence and the changes that have happened as a result of COVID and the amount of nurses that have left the field, right?
Yeah,
So you have nurses who are responsible for more patients
hmm
because they have to be, because we don't have as many nurses care. You know what I mean? So,
hmm
if you've got a floor where maybe there was three nurses before, now you only have two. So the chances may be higher for those two nurses to be in a hurry. So they aren't quite as on guard watching
yeah.
as maybe that third one would be with that little bit of help. So COVID really has kind of changed the landscape of nursing across the board. I really believe that to be true. So it could
It
be part of that.
I think it has, and it's definitely changed and this was happening anyway, but it's certainly changed the experience level or the average experience level, right, on a given care unit or care environment. I was lucky enough to have worked in environments that didn't see a drastic reduction in the number of nurses on a given shift. The ratio, and some people bristle at patient ratios, but that ratio didn't fluctuate a whole lot. It got a little tighter here and there. The little bit of wiggle room that we used to give ourselves was gone.
Right.
But overall, we managed to hold pretty steady. But the stability of the staff shifted, right?
Right.
Both the mental stability in some cases because of the stresses that folks were all experiencing, but
Yeah.
also the experiential stability and just it might not have been your nurses or your peers. It was the float pool, or it was the
Mhm.
contract nurses, or it was that other group who was filling in those gaps, and that certainly did change some of the dynamics and your ability to care. the biggest thing that I saw in terms of in my not super long career, but in my career was acuity creep is where more of that time situation has come from. Task acuity, just the number of tasks, and some of that's documentation, of course, as well.
That's exactly what I was going to
Yeah.
bring up. If about it's not just the fact that we have the amount of things that you have to click on
Yeah.
and chart that have absolutely nothing to do with charting, if you ask me. I mean, not all, yeah, I'm all for let's get data, but there's just some of the things that you're having to, that you have to go through and, for it to be an official visit kind of thing or whatever. It's just so much more than it used to be. So yeah,
Yeah.
but I like that task acuity that makes it.
Yeah. Yeah, because it might not have been the to give it a clear example of that, in our units, I talked about the nursing stability, but our ancillary staff did see a big hit. We
Mhm.
managed to, we were able to, prioritize keeping our nurses in a certain, ratio range, but not always the ancillary folks, our
Mhm.
aides, our techs, our whatever term gets used. And that's, talk about the patient facing and patient expectations, it's the
Right.
folks getting them the water sometimes, not necessarily the person who's dressing their wound. That is why their frustration is there, or
Yeah.
what
So
where
then
it's
you don't
bubbling to the
have
surface.
quite the experience to understand what to look for
Mhm.
that violence creep or that aggression or the irritability and how that escalates and could create something.
Yeah, yeah,
Yeah. Yeah. That makes sense.
yeah. Um, so I want to talk about a couple of the things. I think we talked a little bit about patient dynamics and patient changes, but there are a number of things with our patients that we can kind of keep an eye out for, right? We
Mhm.
talked about the external factors and things that are bringing people in for, but um, does anybody, either of you or any of you, have some clear examples of here are some of the behaviors that you want to. This is a sign that that patient is escalating, or this is a sign that that patient might be um, moving toward a violent action, whatever that might be.
I don't know. It's kind of one of the, I mean, I know there are definite things I can say textbook wise, but it's sort of one of those things sometimes you kind of know it is happening when you see it.
Mhm.
I mean, it's kind of that sixth sense, I guess, maybe on some people, but I don't know. I think a lot of times it's just that the the tent, like they're throughout a
Tension.
shift, they're
Yeah.
just it, like this, they're just kind of like become this little ball. Every time you go in or every time you talk to them, there's just kind of that little
Blowing
just a
up.
little bit more edge, a little bit more edge, and like the teapot, kind of the steam kind of comes kind of thing. So, yeah.
I've definitely seen the person who each time you go in, they're just a little darker shade of red. They've been angry the whole time, but there are some
Yeah, or their
hallmark things.
answers are just shorter, they, have a way of, yeah, just snippiness.
Their answers are shorter. Their teeth stop moving. They just hold their teeth straight. You know.
The
But I've also seen
inability to get
folks.
comfortable. They can't get
Yeah,
comfortable no matter
that's right.
what.
Hmm.
There's no way to comfort them. They almost can't talk to you because they're so uncomfortable. So there's this extra energy, for lack of a better way to say it, in the bed, right?
Hmm.
Extra movement that's not necessarily right
Yeah,
for
I've
the
I've
space
seen
that
it.
they're in.
I've seen it. I've seen it a couple of different ways. We have had near violent events, right? The person, and I've seen the person who, on the surface, you wouldn't think that, maybe violence is happening, but you do feel something, right? It might be that little bit of tension, it might be the fidgeting, but they might be quiet, they might not be making eye contact, and then there's a shift. Something happens, and they're swinging their arm out, making a big gesture, and it's like that's a big sign when there's that sudden change in behavior. I've also seen that the other way. And those are the folks where I've seen nurses actually get struck or hurt, is when it's been that person who's been loud and boisterous and angry. And we talked about this example, I think, in last month with talking about suicidality, and that decision and that change in demeanor with that decision. I think that's what's happening, whether that's conscious or not, is that that person has decided to enact the violence that they've been displaying. And so there's like a soothe thing that happens with that decision, and then they're actually going to do it. And so I've seen both of those cases be difficult. So that sudden change is one of my biggest red flags, is there's just a sudden shift either direction in behavior.
Yeah, agreed.
Yeah.
And I just really want to say that sometimes you just don't know. There's no way to know. It just is very impulsive and it comes out of nowhere, and there's no way warning and no way to know. So we do have those patients as well.
Yeah.
Okay. And some of that is medication. I know we haven't talked about sundowners, but sometimes it's sundowners, sometimes it's a shift in medication that we're not aware that a client, I don't want to call it an allergy, but it could be an allergy that causes that transformation in the patient's behavior. I don't know what you want to call that, but truly, some medications can cause people to just go. Can we say wonky?
I think wonky.
It's a medical term.
Wonky. It's that medical wonky term. And so it comes out of nowhere, and it's all of a sudden, it's like you don't even recognize your own patient 2 hours after medication, right?
A reaction.
Yeah. So that, being aware that and I think sometimes we don't catch that it's the medication.
Yeah.
Depending on who's been in the room with them and who's been talking to them, and, if they've got an irritated or an aggressive family member in the room with them, we could, kind of place it blame on the family member that's with them instead of recognizing that maybe, oh, we gave them a different medication as well, and I've certainly seen that with pain medication.
Yeah.
That can cause those kind of adverse reactions.
Yeah, I worked my background is oncology primarily, and gave a lot of steroids. And I mean that definitely caused reactions.
Yes.
Yeah. So what are and do either of you have any good examples of maybe what are some of the things we can do if we do sense that hey, there's an escalation happening, there's been that shift, or in the moment, right? We don't see it happening, but it's happening now. What are some of the things that we can do to either try and de-escalate or keep ourselves safe or protect ourselves in those moments?
So I want to say the first thing, right, is to make sure that we're not matching their energy. I think that we as humans have a natural kind of response that as people escalate, we escalate with them. And so always being aware of our own voice and our own energies. So trying our very best to stay calm. If we have to touch a patient while they're escalating, tell them exactly what we're doing, why we're doing it in that calm, because as they're escalating, remember, they are not rational. Because as a person escalates, remember, their frontal lobe is not working the way it's supposed to be. They're getting ready to fight. They aren't thinking rationally. So if you can stay very calm, very directive, I'm going to touch you now. This is why I'm doing what I'm doing. Do not match the energy as much as possible. If there's a family member in the room that you've noticed that they're responding very well to, talk to the family member and to that person at the same time. Maybe the family member speaking to them about something very good that's happening might help them redirect the energy a little bit, right? Something good that's happened in their life to make them laugh before you try to move on with whatever you're trying to do. We know that laughter brings people down out of, aggression and anger. So those might be a couple of things that are probably the easiest to do right away before you move into the next steps.
Yeah. Yeah, that's one of the things that I've always really tried to model in my own interactions with patients when they're mine, or when I've been called in to step in and help de-escalate. So the patient's upset about this thing. The bedside nurse is like, this is beyond, it's beyond my pay grade. Hey boss,
Right.
can you take a look at this? I'm like, beyond mine too, but I'll try. um, and sort of stepping in is really, really modeling some of those behaviors. And some of these are not some of these I would question myself on after the fact in a couple places, and I'll explain why in a second. But these are patients who are escalating but did not appear, to my view, to be approaching the violent stage, right? We were still early enough in the escalation pathway that we were not there. And so that volume, coming in at least one or two stages below them, just in terms of volume and emotion in my voice and tone when I was speaking to the patient, is one of the first places. If somebody's screaming at you and you say, yes, I understand what you're saying, and this is what we're going to do, and I'm so sorry that you're upset, like that, trying to just kind of capture sort of their own absurdity and let them sort of become a little self-conscious almost is what I've seen happen sometimes. Get on their level. And that's why I say when it's not approaching an anxious place, because you don't want to get yourself in a situation where you couldn't defend yourself. But when we're before that stage, or appear to be before that stage, I found a chair, even if I had to go out in the hallway and drag one away because the family was using all the ones in the room. I went and found a chair. I want to sit with them and talk to them on the same level as them, and try and approach it that way. Like, I'm not speaking over you. I don't have authority over you. We're working on the same side together. Even literally, when I could, sitting my chair so that it was sitting beside the bed, beside them, and turning to face them this way instead of facing them head on. Just that little silly tricks in your brain that maybe that captures that, like, no, we're on the same side. We're facing the same problem together. We're not opposing, right? And those are things that were sometimes quite effective, and other times, we may have been beyond that stage, even though we weren't at a violent behavior. But I found those to be often very effective.
Really good stuff, Eric. It's really helpful.
When it comes to so escalation has been unsuccessful, and now you have a patient who is threatening or is likely to enact violence, or that has started. One of the things that I'm very, very confident and really try and hammer home with nurses of all stripes who I work with is that you need to defend yourself. You are a key element of the healthcare system, and if we take you out of the mix for whatever reason, as much empathy as you might have for that patient, or as much fear of repercussion as you might have, taking you out jeopardizes the other 4 patients or 5 patients or 7 patients on your assignment, in addition to this one. Defend yourself. If it means that the person who's a high fall risk that you're trying to keep safe, who's maybe a TBI and not in their head, is going to fall, that is what needs to happen, because you're an integral part of this bigger health system, right? It's almost a utilitarian, greater good kind of approach thinking, which is really hard to get in your head and do when you're wanting to do something safe for the patient. And the same is true when it comes to a violent action. I was in a facility where the directive was you could defend yourself to the point of striking a patient if they were actively violent to you, and that was going to allow you to escape. You strike the patient and then you get away, if that's enough to do it. We had policies written for that, and legal was all over it, and we had to have training on all that kind of stuff. But we had some really basic self-defense things, and so obviously don't do anything outside of the bounds of what your organization's policies would dictate, but defend yourself. um, do not allow yourself to be injured in a patient violent situation. That goes to the one-on-one patient situations, and absolutely also to the sort of hallmark worst case scenario of like an active shooter or something like that. You remove yourself from the situation if you can. You barricade yourself if you can't get away, and you fight if you can't barricade. The run, hide, fight is, I think, what the FBI teaches, and what most facilities teach. And that's all about preserving self to prevent yourself from becoming a victim of whatever event is happening, whether that's just this one patient and it's this one situation and it's only the patient that's at jeopardy if you leave, versus other scenarios as well. That comes with a lot of feelings and emotions and baggage. If you've ever been in a circumstance to do it, do you all have any responses to that approach? I can say it as much as I want, but how does it make you feel?
I have to say that it has come a long way from, of course, I'm a little older. It has come a long way from the you're a nurse, you have to take it days, right? So the ability to be able to protect yourself, the ability to be able to call the police, I really do applaud the healthcare system for finally allowing those things. It still makes you feel yucky, right? That's always going to be, because you feel like I'm a healthcare worker. I should be able to handle it. It's part of my job, whatever. But, at the same time, like you say, there has to be a boundary. And I think that part of learning to be a good healer, right, is to learn that there has to be boundaries in all settings for the healthcare workers. And I think that's part of this, right? And unfortunately, there's just some patients that we have to do that with. Yeah.
Yeah. That was one of the hardest things when we introduced a system that included defensive strikes in addition to just sort of the evasive defensive maneuvers. That took some. There's a hard pill for our nurses to swallow in a lot of cases for just what you said. Um, and so it did come with a lot of culture change. And I don't know that I've ever seen it actually implemented by a healthcare worker. But it did give just that little bit extra. No, I matter. I'm important in this scenario, and that I think that went such a long way. I was so glad to see us adopt that um, mentality at that organization. Um, yeah. um, in all of this, and I want to ask if there's any other examples or thoughts or things that we want to get out. I have a couple of things that I was going to share and wrap up, but Deanna or Evie or Mike, any other thoughts or stories that have come up in the discussion that we want to get into first?
Not for me, I don't think.
So one of the things that you said, Deanna, in your last comment, about that's just part of the job. We're trying to change that, and you've identified that as it being a change. Violence should not be a part of anybody's job. And if you, as a nurse who's listening to this or here on the call with us, still have a piece of that, do some work to let that go. There are circumstances, there are patient situations. We've talked about the old folks with dementia. Like there are some truly situations where you want to have all the forgiveness in the world, and empathy in the world for that patient and that situation. But you can burn yourself out very quickly by allowing it. So it doesn't mean maybe we don't treat that with a strike, a defensive strike, but you still remove yourself from the situation. You don't tolerate it while you're trying to prevent the patient from falling. Those are the things that burn nurses out faster, that increases the shortages in nursing, that all the knock-on effects of that as well. Violence should not be a part of anyone's job. And it is not a part of ours either as nurses. If you are in an organization where that is explicitly tolerated, run. Frankly, nurses are needed
Find
everywhere.
another job.
Somebody else will get you. I say that somewhat in jest. We care about our communities, and maybe that's your community, but if you're in an organization where that's implicitly tolerated, right? When it is the scenario where the nurse manager's first question is, did you have to say that? Or what could you have done differently? Or how could you have prevented this? Rather than, are you okay? Maybe don't run, but change something. And I think that is what I would like to leave on. And of course, any other discussion is welcome, but all of these things are things that have changed in the nursing profession, and that has changed a lot of the time through nurses advocating for themselves. This hasn't been a situation where the doctors haven't swooped into our rescue. There isn't some well-meaning administrator somewhere who took this on as a personal cause. This is nurses advocating for themselves. And in some places that's been through, unions and collective bargaining and part of that type of organization. In a lot of situations, it's been through working with professional organizations like, nurses associations and those kind of groups to lobby governments and lobby their organizations to change culture. Professional governance or shared decision making, or whichever term is being applied to those spaces now, those committees and teams, those grassroots places are where these changes are gradually being implemented from, and where they have come from when they've come. In my article, I noted in West Virginia, it is nurses are part of a protected class now for assault. For battery, I should say, for the legal terms, with some caveats. And we're in the same class now that used to only include elected officials, police officers, and corrections officers, I think, and now includes healthcare workers, and there's a few others included there as well. I think utility workers is another. But basically public servants, even though many of us work for private organizations, we're considered public good. But at least in West Virginia, that only has any heightened penalty in a second offense. And so part of our follow-up to any situation where you're assaulted by a patient is to pursue those charges and to push for that. I'm not a penal system believer in general, but this is a situation where it helps to be protective of the whole, and where, particularly when it's somebody of sound mind who has, escalated to that point, to pursue that, to get that on the record. So that way, if it does happen again, those more serious consequences are there, and we protect the future nurses, future caregivers for that patient from those behaviors. They're also heavily correlated with domestic violence, so that's something that you'll see as well. And that's one of those places where, if we can, anywhere you can stop that chain from happening is an important place to be a part of it. So Um, it's a tough topic. Whenever you encounter workplace violence, whenever you have others who encounter workplace violence, maybe you're not the one who saw it or witnessed it or has even been very affected by it, but you see your peers. Um, find some support systems, whether that's an employee assistance program or developing a peer support group. Um, those can be extremely effective in helping to decompress the traumas that come with that, and with a lot of other scenarios that we encounter as nurses. And so take the time to develop those on your unit, to support each other, to be there for each other and build that kind of community. It's hard to do that with 3 12-hour shifts, and you don't want to do that little bit of extra, a lot of bit of extra in some cases, but man, does it make for a more robust workforce. And more importantly, it keeps us all caring for doing the thing that we're passionate about, which is caring for our patients for that much longer, where we're needed most. So those are my final comments that I wanted to put on the record with all of us today. But any other thoughts, discussion, or we could begin our closing.
The only thing that I would say is if something happens to you and you notice an increased anxiety, you're struggling to go to work, or one of your coworkers tells you that they're having a really hard time coming to work every day, please seek out those services, the EAP, counseling, something, and get some help with all of that. Don't struggle by yourself. You don't have to. There's help.
Yeah.